Next second. Hold.
Yeah,
Go ahead.
yeah.
Sir, we are live now.
Oh, fine.
Good evening, doctors. On behalf of INTAS, I welcome you all to this live webinar on new vistas in epilepsy management with a focus on Perampanel. INTAS has always been in the forefront in being a knowledge-sharing partner in such academic initiatives for the benefit of the medical fraternity and for the betterment of the epilepsy patients. It's a proud moment for INTAS to have launched Perampa pan-India on the 9th of June, immediately after the patent expiry, at an affordable daily cost of therapy comparable to that of first-line AEDs. To chair today's session, we are truly humbled to be blessed with the presence of two academic stalwarts and legends in their field, namely Dr. A.V. Srinivasan from Chennai and Dr. T.R. Gyaneshwaran from Madurai. Dr. A.V. Srinivasan, Emeritus Professor, Senior Consultant Neurologist, is a former president of IAN and former visiting professor of Cleveland and Hershey Medical College of USA. He has a distinguished academic record with more than 60 papers in national and 25 in international conferences, apart from being richly awarded across the country and the globe. His Lifetime Achievement Award in Neuro Update Chennai and NSI Coimbatore and Economic Times Award as an inspiring neurologist are some of the few of his many remarkable achievements. I am also happy to introduce Dr. T.R. Gyaneshwaran, Senior Consultant Neurologist, former Professor and HOD of Thoothukudi Medical College, past Secretary as well as President of TAN. His special interest has always been epilepsy and headache. Without much ado, I look forward to you, Dr. Srinivasan, to please take the program forward by introducing the speaker, Dr. Ajit Cherian.
So, somebody is still speaking. I think they can mute that particular. Somebody is just, you can just mute it. And I'm very thankful for giving this opportunity to Dr. D'Souza and the team. And they have done an excellent work today. And they have really thought before. And they have spoken their mind. And we are going to listen to the people who have done their original work in this field. I think I would rather say this present speaker is from Smith, Kerala, Associate Professor Dr. Ajit Cherian. He is an associate professor there with area of interest in epilepsy, movement disorders, headache, electrophysiology, and above all, the golden pulse of clinical neurology. He has more than 123 publications in national and international journals, including multiple book chapters with a citation of 1,615 with a cumulative impact factor of 342. The winner of MDS AOS Virtual Synergies and the Leadership Award 2021, the BMJ Award for the Best Medical Team in Asia in 2015. Winner of the Scholar Award for the International Course in Pediatric Epilepsy in 2012. Venice International University San Verlo and Italian Neurological India Best Paper Award in 63rd Annual Conference of NSI. Short-term fellowship in cerebral ultrasound at the National University of Singapore. We are indeed delighted to have you in our midst, Dr. Ajit. We are looking forward to the words of wisdom on this. I think it is going to be an excellent talk on this subject, which is going to speak today, and especially the patient selections for optimal outcome and a perspective on Perampanel. Only three sentences of Perampanel. I always say that the old and the new is like duality of the brain. You need both. They are the two eyes. One is the body and the other is the soul. You need both to get into the ecstasy of the epilepsy patients. So looking forward, Ajit, please.
Thank you, sir. Thank you, sir, very much for that kind words. Just to check my audio, Dr. Michael, is my audio clear?
Perfect, sir.
Yes, perfect, sir. Perfect.
Okay. And I thank the organizers for this opportunity. And without much ado, I'll just straight away go into the topic proper. So before the molecule, I just want you to know how AMBA works in epilepsy. So if you look at the mechanism of action of the current various anti-epileptic drugs, a good majority are working on the presynaptic molecule. So you have all these sodium channel blockers which are acting on the fast sodium voltage gauge channel, inhibiting glutamate release. And then you have specific molecules like the levetiracetam and the brivaracetam acting on the synaptic vesicle. But we have very, very few molecules which act on the postsynaptic molecules, postsynaptic receptors. So of which one is reticabine, which is currently not available in India. Felbamate is also not available. And then we are virtually left with the AMBA receptor blocking stuff, which is Perampanel. So among the postsynaptic receptor stuff, we have our armamentarium is virtually limited, except for the ones which are the benzodiazepine, which are used acutely. Perampanel is the molecule which has a long-term usage, basically. So AMBA is the main receptor mediating the rapid effects of glutamate. So it is underlies the fast component of the excitatory postsynaptic potential, whereas the NMDA is actually the slow component of the excitatory postsynaptic potential. So what NMDA does is basically it is involved in neuronal plasticity, that is in the act of learning and memory. So whenever you are using an AMBA blocker, we are actually leaving this NMDA blocker, NMDA receptor free, so that the learning and the memory and the plasticity part is left intact. So if you have an AMBA receptor blocker, it actually prevents all the rapid firing, whereas the NMDA receptor blocker, this rapid firing, which is part of the periodic repolarization shift PDS, is not really blocked. So the AMBA is the main mediator, or AMBA receptor blocker is the main one which is inhibiting this PDS shift. So where exactly does it act? So it acts on this non-competitive binding site. So it's a site different from where glutamate actually acts. So once this perampanel goes and binds to this non-competitive binding site, however much glutamate may act here, it doesn't open the channel. So it is just like Rahul Dravid, who just angers here, blocks one end, and it doesn't allow it to open. So it just keeps blocking. So what is the data that we have? So let's look at one of the initial data that is known as a 5-data study. So the mean number of anti-epileptic drugs that was studied in this group was around 8 anti-epileptic drugs have been studied, have been used in these patients. There are 464 patients. And the median reduction in overall seizures was around 30-33. But most importantly, 7.2% of patients were achieving seizure freedom. So despite this being the 9th molecule being added, around 7.2% patients achieve seizure freedom. So that is remarkable. So if you look at this Brody study, so after the first, second, and third, so first will give around 46% seizure freedom, and then 28, and then thereafter. So if you look at the total achieved seizure freedom, it's around 71, 18, and 6.2. But thereafter, after the 4th, 5th, and all, it is not even 1% will achieve seizure freedom. So you can imagine an 8th or 9th achieving a seizure freedom of 7.5%. That's quite remarkable. So that is where the effect of this unique blocking property of perampanel comes into action. So this has to be in perspective with the current whatever available armamentarium is there against epilepsy. So when you look at this aspect, perampanel is a very unique molecule. The second point that the 5-data study had thrown was that perampanel was most effective in patients with secondary generalized seizure. So that was the second most important data which has come from that study. And these patients also had the highest 50% responder rate, and they had recommended a titration once every 4 weeks. So these are the 3 points that came out of that initial data, that was the 5-data study. So I'll just go by a case-based approach. So I'll just give you the first case. He was a 14-year-old boy, second of twin, breech delivery, normal development. He has had habitual seizures since 2 years of age. And there was no aura, brief arrest, right arm and leg dystonic posturing, falls, frequency of 12 to 14 per month. All were daytime events. And he was initiated on carbazepine with a 50% reduction in seizure burden. That it means it came around to 6 to 7 per month. Addition of valproate did not benefit him much. Thereafter, topiramate was added. He had a 50% reduction and it came down to 3 per month. But because of reduced appetite and weight loss, we had to come down on the topiramate dose. So he had this bilateral PHR gliosis that you can obviously see here. And this was a CEG, very frequent posterior head region, both over the right as well as over the left, very frequent discharges that were there. And this was he had this electrical runs on and off, so which were ongoing like that. And you can see this polyspikes, run of polyspikes, which was seen as we see in any gliosis patient. So this very frequent run of polyspikes that you can see. So this is one of the fast focal spikes or run of focal epileptiform discharges or whatever it is. Basically, these are very much suggestive of either underlying gliosis or focal cortical dysplasia. So he had all these entities. So Perampanel was the fourth AED to be tried, and we had tried it 2 milligram titrated level 4 weeks to a total of 6 milligram or 8 weeks. And he completed a follow-up of 12 months. He has had no falls since the addition of Perampanel, and he has had only 4 seizures in the initial 6 months and none thereafter. And thereafter, what I have seen was that after 1 year, we had seen that the EEG became cleaner and cleaner. It is a late to manifest and often may be delayed by as much as 1 year, but that is a very, very important thing about Perampanel. So usually we see this as a phenomenon seen in very broad spectrum anti-epileptic drugs like valproate, the EEG cleansing effect of valproate that we often quote. So the same effect can be seen with the Perampanel also in these patients. Now, do we have any real hardcore evidence to say that these kind of molecules work in this? So there will always be people who doubt whether this is just a one chance effect or is it really that effective. So let's look at this article by Jensen, which came very, very early. In fact, it came in 2002 on the role of glutamate receptor maturation in perinatal seizures and brain injury. So this is the part which I have highlighted. I'll just summarize this part. So he has created this experimental hypoxia in the rodent model. So that they had this rat model where they had created this experimental hypoxia. So what they found that there's an overexpression of the AMPA receptors in the oligodendrocytes. So what happens is that the perinatal brain, there's a high amount of glutamate excitatory because it has to form multiple synapses, multiple dendritic formation, multiple network formation. So a lot of glutamate excitation is happening at the brain at this region. So post hypoxia, there's an overexpression of AMPA to counter the loss basically. So this can be in fact be counterproductive because it can lead to seizures burden. So AMPA glutamate receptor blocking agents reduces injury and seizures at day 10. So that is what he has found in this rodent study. So he has expressed that AMPA glutamate receptor blockade represents a rational strategy in the treatment of perinatal hypoxic ischemic brain injury. So he had in fact followed up this data from 2002 with the 2004 study. And there at that point, topiramate was the only molecule which was available. So he had tried topiramate in this glutamate receptor mediated oligodendrocyte toxicity in periventricular leukomalacia. And what he had found was that this topiramate is actually helping the rodents by attenuating the AMPA kinase receptor mediated cell death and calcium influx. So that was what he has found. And it did not affect the normal maturation or proliferation of oligodendrocyte. And he's expressed that. So AMPA receptor blockade by topiramate, which was the molecule which was available at that time, is a very good way to manage this kind of hypoxic injury. So currently we have a molecule which is much more focused, much more specific, and much more efficacy than topiramate as far as this AMPA blockade is concerned. So that is how this the rationale of use in perinatal injury or posterior head region gliosis and periventricular leukomalacia is concerned. I'll give you another case scenario. He's a 13-year-old boy, normal delivery, normal early development, habitual seizures since 1 year of age. Initially, he has had epileptic spasms and later evolved to a long-stressed phenotype. He has had polymorphic seizures. One was the hypermotor arrested nature seizures, suggestive of a TLA or pseudo TLA manifestation. Then he has had sudden drop attacks and false custody of a tonic seizure. He has had GTCS and extremity macula. So he has the full-blown spectrum of an LGS. And his frequency just kept exponentially climbing to daily multiple episodes with 4 to 6 drop attacks, all daytime events. So he had initially on carbazepine, he was thereafter added on valproate and topiramate, but unfortunately he did not benefit much. Later, lamotrigine, sonazepam were added, carbazepine and topiramate were withdrawn with no benefit. When vigabatrin was added, there was a remarkable improvement in seizure burden, no drop attacks, no GTCS. But however, there was a period when this molecule was not available and there was a relapse. And his imaging showed multiple tumors. So he was nothing but a case of tuberous sclerosis with the LGS spectrum disorder. So this was what his EEG had shown. He has multifocal IEDs that he has had. You can see all the foci, temporal, bilateral temporal, frontocentral. These are the generalized discharges. And this was a GPFA that you can see the burst attenuation pattern. So Perampanel was in fact the 7th drug to be tried, and 2 milligram titrated every 4 weeks to a total of 4 milligram after 4 weeks. He could not tolerate to more than 6 weeks due to behavioral changes. So that is something which sometimes tuberous sclerosis patients, higher the dose you go, sometimes they may have some behavioral issues, and there's no need to really stop the drug. You can actually bring down the dose to something like 5 or 4 milligram and keep it there. And he has had no falls or GTCS since the addition of Perampanel, and he has had only minor seizures in the form of behavioral arrest at 6 per month. And then what was remarkable was that he has had a EEG cleansing effect after 12 months. So his GPFS started disappearing. His generalized discharges started disappearing. His burst attenuation pattern started disappearing. So this was a remarkable EEG cleansing effect that I have noticed in this patient. So is it just a one-off effect? No, actually, if you look at this data by Kedemure, which has been published in Journal of Seizure in 2020. So they have shown the effects of Perampanel in patients with the behavioral problems in the adult patients. And this was one example of the EEG that which I've taken from the article. The very, very bad EEG with the generalized discharges that you can see, and how the EEG has become 6 months after adding Perampanel. So this is the remarkable EEG cleansing effect which he has shown. And this is not seen with few of the other newer medications. So this actually improves the behavioral side effects, behavioral quotient of the individual. So what they did was the aberrant behavior checklist in the Japanese manuals was done. And what they have found that 8 of the 14 patients who were considered responders, of the 6 had a remarkable response in the EEG pattern also. So after the EEG cleansing effect was seen, there had been a very remarkable effect on the behavioral pattern of these individuals also. So it's not just one-off case that we have had. We have had so many multiple cases or so many other patients also, and data is available regarding the EEG cleansing effect of Perampanel. So this is regarding the second case. Now I'll go to the third case. She was just a 19-year-old girl, normal delivery, normal early development, habitual seizures since 2 years of age, polymorphic seizures. She had the classic supplementary motor area seizure, the classic fencing postures. Then she also had the generalized tonic seizures of sudden drop attacks and GTCS, right upper limb myoclonus also. So lateralizing to the left cortical area. So what we had was she had a very, very large FCD. You can see this in the CT, the thick cortex that you can see. This is known as the CSF dimple sign or CS cleft sign, which is often seen just superior to a large dysplasia that you can see here. This is the hyperintensity that you can see, and this is the T1, which shows that the thickness of the gyri, that's it. So this was virtually in the supplementary motor area, and we had in fact advised her for a pre-surgical management. We thought of taking her up, but the parents, when we had explained that there's a possibility of pyramidal dysfunction, probable pyramidal, they were really reluctant to go out with the pre-surgical. So I had added this child on Perampanel, which was the first anti-seizure medication which was tried, and 2 milligram, I titrated every 4 weeks to a total of 4 milligram and completed a follow-up of 12 months. She has had no falls, no GTCS. So that is the next important thing. The generalized seizures come down remarkably. there will not be any tonic seizures or GTCs. That is the most remarkable thing once you add the perampanel. So this is what the parents are really worried about. The injurious falls, the drop attacks, which injures the face or the scalp, which are really, really bruising to the child. So no falls, no GTCs, very minor right upper extremity myoclonus or posturing at 3 per month. And these are very, very sort of partial seizures. Her awareness is not at all affected. And the parents are happy with the current management that we have had. So what are the current indications for perampanel? So the best response that you see is basically in generalized seizures of focal origin. So focal origin, generalized seizures. So with seizures with secondary generation, this is the key stuff where perampanel will work the best, especially those with fall, especially those with tonic or atonic falls or GTCs, as monotherapy or as auxiliary therapy in children more than 4 years. That is the current indication for perampanel. The other indication is actually primary generalized epilepsy as an adjunctive, not as the primary drug, as an adjunctive after 12 years. So these are the current 2 indications for perampanel. A bit on the pharmacokinetics and the important interactions. So perampanel is metabolized by the oxidation and glucuronidation by the cytochrome system. So there is some amount of the inducers which can reduce the effect of perampanel. So you may have to go up a higher dose, like around 6 or even 7 milligram. You can give 6-8 milligram alternate day to reach a dose of 7 milligram. In mild CRF, no dose adjustment is required up to a GFR of around 50 ml per minute, but thereafter you may have to go for a dose adjustment. And 50% reduction is advised in moderate liver disease also. It may reduce the efficacy of OCPs, but this is not of major concern in the patient population, especially in the young adults or children that we are daily managing. So coming to my experience with perampanel, I have had 132 patients currently where I have used. I have not used it in any primary generalized epilepsy. The main reason was that I am yet to have a primary generalized epilepsy where valproate, ethosuximide, or zonisamide, either alone or in combination, has not worked. So I am yet to see a refractory case now. I have not used perampanel in any geriatric patients, that is more than 60 years. My best response is basically in the generalized seizures, focal origin with secondary generalization, especially those with falls, as I've said, the tonic, atonic, and GTCs. And mainly, it's my experiences with the pediatric, adolescents, and young adult individuals, all less than 40 years. So where all I have used, so basically it works wonders in perinatal insult with parieto-occipital glycis or central leukomalacia. So this is one of the bulk patients where you have bilateral pathology, bilateral occipital, mesial occipital glycis who are not surgical candidates. This is the patient. And used in tuberous sclerosis, dysplasias, all malformations of cortical development I have used, band heterotropias, periventricular node heterotropia, as well as in tumoral epilepsy, vascular malformations. I've also tried in encephalitis, reflex, mitochondrial cytopathy, and post-traumatic epilepsy. And let me come to where perampanel works well. So this is what we are all looking for, where perampanel works well. So it has to be used as the first or as the second add-on anti-epileptic drug in the following conditions. Perinatal insult with parieto-occipital glycis or leukomalacia, tuberous sclerosis, very, very, very effective. Lissencephaly, band heterotropia, polymicrogyric cortex, almost all of these malformations of cortical development, it really works well. Reflex startle epilepsy. So these are the large porencephalic cyst variant where you have a very in utero or fetal life vascular insult. These patients also remarkably does well with perampanel. Focal cortical dysplasia, as I have shown, both type 1 and type 2. The temporal polar epilepsies, the occult MRI negative ones also will respond. Patients with the tendency for hyperammonemia on hiking valproate, topiramate, or zonisamide. Many a time we have seen this because you cannot hike up topiramate as the first child which I have shown. I could not hike up topiramate beyond a certain point because of hyperammonemia and anorexia which is being caused. So in these patients, actually bring down the topiramate, add perampanel, you can see the remarkable benefit. And patients who have shown a response to topiramate, that's a clinical clue that the AMBA blocker has done some impact in this child. So that is a clue for you to add perampanel. And I also had recently a very effective outcomes with progressive myoclonus epilepsies as well as in the Dravet syndrome. Now, is it just my reflection alone? So actually there's so much of data which is already available. So if you look at this paper which has come in epilepsy research in 2016, they have tried in the refractory epilepsies in the adolescent and children. So this is exactly the same age group individuals which I am working basically as a surgical epilepsy center. So this is exactly where patients who have bihemispheric pathologies, who are not ideal candidate for a resective surgery, resective epilepsy surgery. This is where I have mainly used the Perampanel. So in this study, which has come in epilepsy research, 62 patients with refractory epilepsy, 53% males, and the mean number of AEDs which have been used was 7.1. It's almost like the 5 data where 7.9 was the mean AEDs which are used. And what was remarkable was 16% achieved more than 75% seizure frequency reduction, and 5% became completely seizure free. Remember, these are labeled as refractory epilepsy, sent for some surgical intervention or VNS or chiropractic. So to make them seizure free is a remarkable achievement. So let's look at where they have really done this magic. So this is the group of 75% responder rate. If you look at the epilepsy spectrum, these are predominantly Dravet, LGS, epileptic encephalopathy. These are very, very bad focal epilepsy with HI, hypoxic ischemic injury, or peritonitis, CME infection, cortical malformation, or parotoccipital atrophy, gliosis, hemispheric atrophy. So very bad epilepsy spectrum. And if you look at the seizure frequency, majority had daily seizures or weekly seizures. And if you look at this last column, which I have marked here, and the mean Perampanel dose was 4 to 6 milligram, and almost all have had a 75% responder rate, that the seizure burden coming down by 75% or more, and a good majority, at least a part of them becoming seizure free also. So this is where your use of Perampanel should be focused on. Now I'll just tell you where Perampanel may not work. So suppose if you use Perampanel in this subtype of seizures, you may, if you are using this initially in these subtypes, you may feel that, okay, this molecule is not very useful, and you may stop having the belief in the molecule, and you may stop using it where it actually will work. So it may not work in hypothalamic hamartoma. I'll tell you why it may not work. Because hypothalamic hamartoma lesions are composed of both small and large neurons, which are poorly demarcated. And 90% of these hypothalamic neurons are predominantly GABAaminergic and exhibit an intraneuron phenotype, where demonstrating intrinsic pacemaker firing activity. So basically, these are GABAaminergic interneurons. And the large hypothalamic hamartoma neurons, which are less abundant, possess the functionally immature property of depolarizing and firing in response to GABA ligand. So that is how they fire. Basically, it's by a reversal of the transmembrane chloride gradient. So usually, it reverses the transmembrane chloride gradient. So it increases the excitatory. Instead of GABA, which has to cause inhibitory, which has to act at an inhibitory ligand. Because of this reversal, it acts like an excitatory ligand. So here the mechanism itself is entirely different. So maybe when you use this molecule, the AMPA receptors doesn't have much of a role to play, and that is why it may not work in this kind of epilepsy spectrum. So which are the other subtypes? It may not work in hypomotor focal seizures, especially pure MTS, pseudotemporal, insular, or hypothalamic hamartoma. So I haven't had much of benefit in these kind of cases. Autosomal dominant nocturnal frontal lobe epilepsy. That is a subtype of the FLE or frontal lobe epilepsy, where it is basically due to a nicotinergic mechanism. So this is where it acts. So the network doesn't has where the AMPA receptor doesn't play much of a role. So that may be the reason why it may not work. I have had failures when I have used in this one. Patients who have failed topiramate in the past, that is actually a clinical clue for you. Not maybe if I use Perampanel, it may not work. Post-encephalitis sequela. So this is something which is the other subtype where we usually see some occult virus. It may be herpes, it can be adeno, it can be echoentro, post-encephalitis sequelae. But I have had failures with post-encephalitis sequelae patients, and reflex-eating epilepsy, it doesn't work at all. And one word of caution when you're using in extreme subnormal injuries, that is IQ less than 30, there's a chance of increased aggression when you go beyond 4 or 5 milligram per day. So we need not reduce, we need not stop the medication. All we need to do is just bring down by 1 or 2 milligrams. That's all that is. So this is just a word of caution. This I have seen only in 1 or 2 cases where the IQ is less than 30. Otherwise, it's all fine. So that's all I have to say regarding the molecule. Thank you for the opportunity.
Are you able to hear me?
Yes, sir. Yes, sir. Yes, sir. Yeah.
Thank you, Dr. Ajit.
Thanks.
I think it is one of the best lectures I have listened to.
Okay.
And now, I think we need the experience of all the people here. I just want to say Dr. Sanjeev CC from Senior Consultant Neurologist, Apollo Hospital, Bangalore, Dr. P. Santosh Kumar, who has come from the Neurology Department, especially from Siddipet Hospital in Telangana, Dr. Sai Satish Kandaraju, Consultant Neurologist, Yashoda Secretary, and Dr. 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 Sudhir Kumar, consultant neurologist coming from the Apollo Hospital, Hyderabad, and Dr. Shiv Kumar, senior consultant neurologist from the Sakra Hospital, Bangalore, and Dr. T. Kalpana, consultant pediatric neurologist, KIMS Hospital, Trivandrum, with Dr. Divya, assistant professor Schmidt, Trivandrum, and Dr. Umar Kazan, the head and the department and senior consultant, Department of Neurology and Interventional Neurology by Baby Memorial Hospital, Calicut, and Dr. Fiji Shako, Professor, Jubilee Mission Medical College. Now, I request all of you to just give your opinion in this order so that we can get to know from your views on this. I will just pose some of the questions to you and let's see how far. Now, the first question is to the speaker itself. It has been done in Delaware that it is not the neuronal hypertrophic firing, it is actually a synchronous firing of the astrocyte that stimulates the neuron. Now, do you find any difference in the really one where they have shown the astrocyte? Literally a synchronous.
Sir, the voice is low.
Yep.
Yeah.
Hello?
Now the voice has come, sir. Yeah, now it has come, sir.
Now it's come. No.
Now it has come.
The synchronized astrocyte firing really increases the firing of the neuron. Your words on that, and how does it relate to the non-AMPA group?
Again, sir, your voice is not coming, sir.
Oh, hello.
Sir, if you put this mic closer to you, sir.
Yeah.
Okay.
Now are you able to hear me?
Yes, sir. Yes, sir.
Yes, sir.
Sorry.
Yes, sir.
Now I just wanted Dr. Ajit to answer. It is the astrocyte firing synchronized that results in the neuronal firing. What's your answer for this perampanel?
Sir, actually, glutamate is the key excitatory stuff. So once it is actually released into the synapse, so what happens is that there is a sucking up of the excess glutamate by the astroglial system. So what happens is if the astroglial, a pathology in the astroglial can increase the glutamate levels in the synapse, so which can lead to a continuous hyperexcitation or EPSP at the postsynaptic neuronal membrane and leading to a paroxysmal depolarization shift. So the current concept is that the neurons are important, so is the astroglial system also. So that is how the astroglial has also come into the picture of hyperexcitability.
Thank you. Now I request each one of you to please give your experience in perampanel, the order in which we have read, because instead of asking questions, I thought we'll leave this open to each and everybody, the panelist members. It should be an open one, and there's not a reserved one. And I always felt that each one of us can have their own free thinking and free expression, and of course, the success rate in perampanel. So many things, I'm not purposely raising it now. I just want the experienced people here to give their thinking. And with first one, I want Dr. Jnaneshwaran to speak and ask questions if necessary. Any other person whom he thinks he wants. I want his first opening remarks and then the final remarks also by him. Yes, Dr. Jnaneshwaran.
Sir, kindly unmute yourself, sir. Sir, unmute yourself.
And
Ganeshwaran,
all the others to.
sir, it is mute. Ganeshwaran, sir, it is mute.
Please unmute, sir.
No.
Sir, now it will come. Now it will come.
We have to appreciate Dr. Ajit because 132 patients, number of patients is not a small number. So taking that number, compared to that, I think I might have treated around 1/10 of this number. So, and whoever was put on Perampanel did well, and almost the guidelines have gone according to his guidelines only. But this EEG cleansing effect is one point which I have not checked so far. I think that is a very important point one has to ponder, because it happens only with sodium valproate. We used to see cleaning effect, EEG cleaning effect. I think next to that, Perampanel he has demonstrated also. We have got a little experience as compared to Ajit, so we will get others' opinions also. So, other panelists, please opine.
Sir, Dr. Shivkumar here
Yes.
from Bangalore. Yeah, I congratulate Ajit for his wonderful deliberation on the experience of Perampanel. Huge experience, 132 patients. I have experience of using in about more than 50 patients, roughly around 50 patients. I would like to make a few comments here. The place where we have found Perampanel to be more useful, particularly in someone who has got post-hypoxic ischemic injury and myoclonus. So we have found this drug to be very, very useful without any systemic side effects. Excellent control of myoclonus, where valproate and levetiracetam has not worked for controlling the myoclonus. So this is one other indication where a clinician can use for refractory myoclonus, that is post-hypoxic myoclonus. Perampanel has got very good control. So you can use this without much side effects on the systemic thing. The second thing is, we had few children where we found they came with a history of sudden drop attacks after the Perampanel was started. So one should be very, very cautious in someone who has got atonic or drop attacks, particularly, and if they come with history of sudden falls, Perampanel could be a drug which is one of the culprit for causing sudden falls. The reason for this is not known in literature, but if there is any history of falls in people who are using Perampanel, one has to be very cautiously or slowly titrate the dose over a period of maybe around 3 to 4 weeks. You can hike the dose rather than increasing at 1 or 2 week interval. That is the one other experience what we had. Otherwise, it's a wonderful drug, and we have not used in primary generalized epilepsy so far. As Ajit told, we have very good response to valproate. So when valproate is working, I don't think Perampanel has got too much role in primary generalized epilepsy. Otherwise, our experience with these 50 patients have been good, and most of our patients are difficult to treat epilepsy patients. So first add-on, second add-on, the experience is very limited right now.
Thank you, Shiva. So that was an excellent point regarding the Lance-Adams syndromes, where Perampanel may also have a remarkable role. Second thing is regarding the titration in children who are weighing less than 10 kg or very low weight. So I may not even give 2 milligrams straight away. I give 2 milligrams on an alternate day basis initially. I will go really slow, because I don't want the parents to have a negative opinion about the molecule because of my hurry in titration. So I go 2 milligram alternate day for 4 weeks. Then I go 2 milligram daily. Then I go 2 for alternate day. That means a mean of 3 milligram. So it has to be really slow. Just like you titrate lamotrigine, you have to be very cautious and slow in titrating, because you don't want the parents to have a negative opinion about the molecule straightaway, because this is one drug which is going to work. We know that. So that is one important point that Dr. Shiva has pointed out.
I'm Dr. Sanjeev CC. Can you hear me?
Yes, sir.
Yeah,
Yes, yes.
Bangalore. First of all, I have to congrats to Dr. Ajit Charian. I know him through our MDS group. Well read and well enlightened us. I'm basically a movement disorder specialist. I'd like to give you a small experience with this thing, Perampanel. Of course, I'm using for epilepsy also. Recently, I had an elderly lady with ACA infarct, and she took myclonus. And which is reported in the literature also, cortical infarcts with myclonus. And we tried with clonazepam and levetiracetam and valproate. But she continues to have attacks in between. When I started Perampanel, of course I used the Intas only, Perampa. Beautifully, it was well controlled. And the whole family were happy because she used to suffer in between the attacks, despite using 3 anticonvulsants. So it is one of my pleasant experience with the Perampanel. I would like to recommend people who are in here, especially used for myclonus, which are not controlling with the routine drugs.
Okay, sir. Thank you. The same I have noticed in PME syndrome also. Unverse Lundborg, that is the Baltic myclonus, which can be very, very difficult to treat. I have found that when I have introduced Perampanel, along with the combination of sodium valproate, I have had a additive effect or a synergistic effect in the control of myclonus.
Dr. Ajit,
Yes, sir.
Dr. Sanjeev, Dr. Shivakumar was telling about the falls
Yes, sir.
due to Perampanel.
Yes, sir.
What is your comment?
So
What is
personally,
your comment regarding falls?
personally, I haven't come across falls during with Perampanel. The thing is, initially I was titrating once every fortnightly. So once every 2 weeks I was titrating. So I have had parents coming back and saying that my child is not at all tolerating. He's feeling sedated, excessive daytime sleepiness. So I don't want my child to be like lethargic like that. I would rather have him, let him have seizures rather than have a child who is looking so obtunded. So that was the initial feedback I have got. I haven't, to be frank, I have never had a child who had started falling after introducing Perampanel. But once I reduce the speed of titration very, very slowly, no issues. This was basically because of my hurry in titration initially, in the initial days of usage of Perampanel. Thereafter, I haven't had any issues.
Thank you, Ajit.
Srinivas sir, you are muted, sir. Srinivas sir.
Very good point. I always say, start very, very slow, very, very slow. Increase it very, very slow to assure the sure success in Perampanel. If you miss it, then the problem comes in falls. There are 2 ways. In Dr. Of course, from the Kerala, Rajshekharan Nair wrote it long time ago, the type of seizures, complex partial seizures in those days. Type 1, type 2 and type 3, where there is a sudden fall, followed by automatism and then generalization or resolution. These patients do not have it in their temporal lobe. They have it other than the temporal lobe. Now, I also looked at it. Yours is a Pareto temporal. It's a very good one when you look at the lesions. But when it goes into the periphery of the frontal lobe, then the problem starts with the fall. And what is your experience, Dr. Ajit? Have you localized with the CT, especially really the recording from the frontal lobe?
Okay, sir.
Yeah.
So if you are asking me regarding frontal lobe epilepsies, where Perampanel may work,
exactly.
That's a subtype. Okay, I can exactly give you. The frontal lobe epilepsies, I have basically it could be dorsolateral, mesial frontal, frontal polar, opercular, frontal opercular, and orbitofrontal. So these are the subtypes. So orbitofrontal will present, and frontal opercular can present you with pseudotemporal manifestations. So there, Perampanel may not be a good choice. But in the dorsolateral and the SMA subtypes, that is where Perampanel really works. So these are the ones which are going to present you with the drop attacks or sudden SMA seizures. That is where you have to use Perampanel. You're going to get the best results out of using this molecule.
Any other for Dr. Divya, Dr. Kalpana, please, and Dr. Chako?
Yeah, that was an excellent presentation by Dr. Ajit. Just because the problem of falls came, I'll just add that recently, maybe in 2020, there were many papers with Perampanel in many of the movement disorders, different from epilepsies. It was actually one of the, it was recommended for orthostatic tremor. It was found to be very, very useful at 1 milligram per day. Especially in people who were elderly, and also for essential tremor and restless leg syndrome. So essential tremor, they went up to 4 mg, but for orthostatic tremor, even patients who were not responding to 12 mg of clonazepam, and where our armamentarium is very limited, 1 mg of Perampanel had made much of a difference for orthostatic tremor. So it's just by the glutamatergic mechanism. And also for other indications like chronic insomnia and especially restless leg syndrome, they found Perampanel was really useful. And it was actually in fact used for one of the studies in Parkinson's disease also, where there was no much benefit in Parkinson's disease. That was because they thought that because amantadine worked through the glutaminergic pathway, they proposed that even Perampanel may help. But Perampanel did not have any effect in Parkinson's disease, but they found that these falls were higher when it was tried in patients with Parkinson's disease, especially in the geriatric age group. So maybe with the same mechanism that was working. So just like it prevents the paroxysmal depolarization shift, Perampanel, by its AMPA blocking action, it prevents the hypersynchrony in the Purkinje cell complex and has been found to do good in essential tremor as well as orthostatic tremor. I really don't have any first-hand experience on tremor disorders with Perampanel, but I hope, like now we are using with epilepsy, but I hope once the cost comes down and we have too many runners in the market, we'll be able to use for other movement disorders as well. So that will be a good tool in our armamentarium and for these disorders as well.
What was the dose you used for essential tremor?
1
It
mg.
was 4 mg. It was approximate. By 4 mg, they had a benefit. They had up to 50 to 80% benefit in the group. But orthostatic tremor, it was 1 mg that they had used.
And what's the dose for falls in Parkinson? Do you start with a very low dose and?
No, they had a side effect of fall, actually. They didn't help Parkinson's disease. So it did not help Parkinson's disease. It did not change anything in the dyskinesia or the motor fluctuations, but the falls were slightly higher. So it was not tried for Parkinson's disease there.
Okay.
Mainly it was essentially for essential tremor as well as for orthostatic tremor that the best benefits were seen.
Hello, I'm Dr. Kalpana, and first of all, I congratulate Ajit for the very beautiful presentation, very informative also.
Thank you.
I'm a pediatric neurologist, so my patients are younger children, and I was getting very good response to the Dravet syndrome when we are not having this tiripendol available, and it is very costly also. And when this was started on a child, actually I have used it in Dravet syndrome for about 3 patients, and 2 patients became completely seizure free, and 1 patient there was more than 50% of reduction of seizures. So Dravet syndrome, and I could reduce the other drugs also comparatively. So one valproate and clobazam as well as this Perampanel, the patient became seizure free. Other drugs, topiramate was there and the levetiracetam was there, and all these drugs where I was able to stop the drugs. Then another one is actually in 1 or 2 post-encephalitic patient also I have tried, and there was a reduction of more than 50% in that patients. It was not a complete reduction. And then, as Ajit has said, the hypoglycemic brain injury, when there is a occipital gliosis, and it is always associated with recurrent falls and daily seizures, there was more than 50% reduction in the number of seizures, and the generalization also has come down. And this dose regarding, actually, I have used it from 1 year of age, and I'll be starting with like a point, that is 1/4 of a tablet on alternate days for the first 2 weeks, and then I will increase to half, that is 1 milligram, like that. And the complaints that patients say was, one was sedation, and rarely there was hyperactivity and aggression. And this balance, like dizziness also, they used to complain of.
I
I
agree
think
with you.
below
The
the age
study,
of 4. Sorry.
Below the
Please,
age
sir,
of
please.
4. Below the age
Below
of
the
4,
age of 4.
the FDA approval is not there, but there are large number of studies where they are using, even a clinical trial is there in children less than 1 year on Perampanel. And less than, actually, younger children used to tolerate the drug better compared to older children. That is what the studies tell. It is actually, it is not FDA approved below 4 years of age.
now don't worry about that, because in Japan they have upgraded and they have done the study and they have approved it.
Okay.
FDA is not approved, so let's not make, when whatever the East does, the West does not agree. In the beginning, later they agree. So the Japanese group have agreed, which is one of the most important factor that you have to take it into consideration. I think I agree with you. That is the very small dose. If you take it, I always call it AD, mnemonic AD. 5 A's and 5 D's will definitely missed in the, because the first is anger and assault can be reduced, abuse potentials come down, especially the ketamine effect will not be seen, aggression, anxiety, and as well as acute psychosis you don't see. That is 5A in Perampanel. If you use it this way, go slow and slow dose. The same thing is true when you want to take the 4D. I call it 4D. AD is after. Now, depression, delusion, delirium, and as well as dizziness and disorientation. See, this sort of a AD approach, see, when we use it like that, that's it. I think you have touched that point very well. Low dose, go slow. I think success story in Perampanel is start low, go slow, and you will miss all these ADs once again. I think you have rightly brought out those 3 cases, Kalpana. I think any other opinion from somebody? I think
Dr. Piju Jaco.
Good evening.
Yeah,
Good evening, sir. I have experience in 10 patients only. There was a very good response in one problem child who was on 7 anti-epileptics and a problem in the school. Every other day he has a seizure in the school, and the teachers forcibly ask parents to keep at home. We will give you all pass. We will promote the child to next class. Don't come to class because you are having a seizure every other day. He was already on 7 anti-epileptic drugs. It was slowly titrated, and by 3 weeks or so, he was seizure free. He could attend classes, and the teachers and parents were very happy and started referring patients to me. That's a success story. Then another patient had an SPH. Sometimes in elderly SPH, 85 plus, they improve and then they have a focal seizure and EG documented focal spikes, and they don't respond to 1, 2, 3, 4 drugs, and there's a good response with this. The wife and family wanted to decrease this after 6 months or so, stop the drug, and 2 weeks later the focal seizure, the twitching, like something like epilepsy partialis, continue coming again. Once you stop the drug also, the seizures come after 2 weeks because of the low half-life. Third is someone else had put a patient on Perampanel, a veterinary doctor's father, an elderly person, 85. He was behaving oddly. He sent me pictures. He was squatting under the dining table. 85-year-old, very difficult to walk, was afraid, fearful, and squatting under the dining table. And the prescription showed levetiracetam and Perampanel. Probably it was hyped up too soon. And once Perampanel was stopped, even though he had a few focal seizures, this behavioral changes improved. These are some experiences I would like to share. And I have a query. In tuberous sclerosis, if vigabatrin is difficult to procure due to quarantine and very strict lockdown, can we try switch over from vigabatrin to Perampanel?
In fact, yes, I initially had a lot of cases of tuberous sclerosis who came to me during that period where vigabatrin was unavailable. There was a period when it was not available in the market at all. So that was the time when I had used Perampanel in these patients. Actually, I wasn't very sure whether it will help or not. But then I realized that there is an amount of glutamatergism in all these cortical malformations, whether it's tubers or large malformations of cortical development or band heterotropias or nodular heterotropias. So there is a glutamatergism which is AMBA mediated, which has to be blocked. So I have had excellent response in these subgroups, which I have already shown as case 2. So you can try it actually there. And one more point, as Dr. Shiva and Dr. Sanjeev and Dr. Kalpana Madam has pointed out, the anti-myoclonic effect. One was in post-infarct myoclonus, one was a hypoxic Lansana myoclonus, the other was the severe myoclonic epilepsy of infancy, also known as the Dravet. And my own experience in PME syndromes are all putting together saying that this has got a very, very strong anti-myoclonic effect drug and can work synergistically with valproate in these patient subgroups.
A word of caution. I always say when we are going to use it in the myoclonic epilepsy syndrome, please exclude depression and as well as suicidal ideas in such patients when they have it for a long time. This drug should be used with caution. And this has come as a Schedule 3 of the FDA itself for 2 reasons. One for this and the other one for addiction. See, the drug straightaway went to Breveracetam went to Schedule 5. In Australia, it became to Schedule 4. And this Perampanel came to Schedule 3 with regard to this drug. These points must be known when you give it. But to a greater extent, when you use the go slow and with an increased dose, you can get over this problem. And it has a very good effect. One of the doctor's brother, who is in Madras city, responded beautifully to myoclonus when we added this. Once again, I agree with you. I think it's a good drug. But only thing is, we start him on 1, see whether there is any increase in the depression, then went to 2 on the 2nd week, then 4th week, 6th week, 8th week, we increased and we came up to 6. Unfortunately, he started developing the liver symptoms, so we had to withdraw. He's one of the doctors who helped me to get the first INA award in US. Yeah, next, any other symptom that you have seen? Or any practice pearls that you want to give? Dr. Ashish, Dr. Neil Kamal and Dr.
Dr. Sai wants to say something.
Yeah, sure, please, Sai.
Hello, sir. Good evening, everyone. I would like to congratulate Ajit sir. That was a beautiful presentation as usual. And it's good to hear too after a long time, sir.
Yes.
Sir, regarding the experience with Perampanel, I do have a little experience, not as huge as yours. I have tried in around 10 patients, but majority of them in status epilepticus. As we know that once the patient lands in status, there will be internalization and trafficking of these receptors. The GABA receptors come down and there will be overexpression of the excitatory receptors. I have found useful in treating status epilepticus, especially when there are 2 IV anti-epileptic agents did not work. Loading Perampanel with around 12 to 16 milligram that through the Riles tube, that really helped in controlling the status. I have tried in 5 status epilepticus, 3 responded, 2 could not. And regarding the usage of Perampanel in focal epilepsies, yes, my experience is divided because few people have responded, few did not. Probably I did not look into depth as you had looked into, sir, like the etiologies and all. My experience, generalized epilepsy is, I would say I'm yet to try that. So I have a good experience and confidence in treating status epilepticus with Perampanel. Thank you, sir.
Thank you, sir.
Sir, can I have a short presentation? Here?
Okay.
Your comments.
A short presentation regarding this, is it possible? So that.
Yeah, please. Our time is 9:30. That's what they have written.
Okay, sir. Thank you very much.
But we have to give the last golden 10 to 15 minutes for Jnaneshwar to sum up.
Yeah. Thank you, sir.
Chinmay, please help, sir.
Huh?
Chinmay, please help, sir.
Yeah, I'm doing it, sir. I'm doing it, sir.
Yes, sir.
So there is a green color button, share screen. So there, down. So if you see, yeah, it has come.
Now I'll see.
So you have to select the
Yeah, it was there initially. I'll just whether I can go back.
Perfect, sir. Perfect.
Yeah. Thank you very much. Thank you, Srinivasan sir, and all of my friends. And Ajit, it was a very wonderful talk, and I really learned a lot from your experience. Thank you very much.
Thank you, Dr. Umar.
Yeah. So I just would like to share one case. It's a 26-year-old male. He was found hanging on the ceiling fan. He had a history of depression. Actually, he was found by his brother at 2 p.m., maybe after a few minutes, and he was immediately taken to the hospital where he underwent all the routines and the CPR and all. And when he arrived at this hospital, at a local hospital, his Glasgow scale was around 4. He was intubated and ventilated and referred to our hospital. And he continued to get focal with the secondary generalization. And the MR showed a subtle hyperintensities initially. Very subtle. And the EG showed diffuse slow slowing. There is no epileptic abnormality, but there is a diffuse slow slowing only. So he was referred to our facility because of the uncontrolled seizures. He developed myoclonic seizures as well, focal and secondary generalized, and he was given the low loading dose of fosfentoin levetiracetam after the loading doses, along with the prednisolone, thiamine, and all supportive care. Gradually, he was tracheostomized and was weaned off from the ventilator, but he continued to get recurrent fits focal with myoclonic epilepsy, many episodes even per minute. He appeared dazed and with no purposive eye or limb movements. This I'm sorry for it's upside down. Here is some sort of a continued myoclonus. At times his eyes go to one side, and this goes on like that for hours all together. So his anti-epilepsies were hiked. We added a clobazam, paracetam, lacosamide, everything continued, and still he continued to get fit. And fifth anti-epilepsy was like oscarbazepine, but he developed more drowsiness, and the LFT became abnormal and was withdrawn. MR repeated showed this sort of basal ganglion diffuse cortical hyperintensities. So he was started on brivaracetam 50 milligram BD initially, followed by 100 milligram BD. He started improving. His fits subsided and he started smiling with eye contact, and many was positive. And he was also managed for his contractures. Later on, he developed fever, X-ray showed aspiration, and he again continued to get focal with the secondary focal fits and myoclonus. So at that point, video also showed spikes and slowing and sharp waves. It's not here because I couldn't record that. Then he was started on Perampanel 4 milligram as a 7th add-on medication. And his EEG became almost normal. The slow waves and sharp wave became improved. And gradually he improved, and anti-epileptics were withdrawn sequentially. Presently, he's on only brivaracetam, lacosamide, and Perampanel 4 milligram per day. All the other four anti-epileptics were withdrawn. And later on, he improved, and he's better. Better means there is no fits. Contracts also better, and he's he's communicating with eye contact, with eye blinking and other things. This is him. It's much better now. It's much better. He's looking around, he's smiling, and the myoclonus and conducts also better. So I would like to share this. And before that, I had one patient with encephalitis, post-encephalitis sequelae. He had 5 anti-epileptics. So I thought of starting him on a Perampanel. So then I told him it's a new drug, it would work. But he came back with a flurry of seizures. Then actually I had to drop Perampanel in that post-encephalitic. But I think he responded very well to this hypoxic encephalopathy. So thank you very much.
What doc?
Sir, you have to unmute.
Thank you, Dr. Kumar. You have once again proved that experience is better than expert is better than the evidence-based medicine. And the evidence-based medicine, of course, Professor Blau used to say statistics are the paralysis of your analysis. So don't go by too much of statistics. At the same time, have a statistics for your approach. Lovely case, beautiful. Any other point from anybody?
I would like to make a comment.
Yeah, please.
Dr. Umar.
Yeah.
Locosamide can exaggerate the myoclonus. You should be careful.
Yeah.
Using multiple drugs, the cause for myoclonus could be drug induced. We cannot totally rule out.
Yeah, but he had this myoclonus at the outset. He continued something like a myoclonic status. So we tried everything it was not working. So we added 1, 2, 3 like that. Not but some drugs he would cause hyponatremia, LFT, abnormality, more drowsiness. So we added maybe after 3 days, 4 days like that. Until because every time we get a call, so we have to give injection lorazepam. I mean we have to give benzodiazepine as a rescue medication. So we thought of adding one after the other. That's the reason. It is not just myoclonic. He had a focal with secondary generalization as well as myoclonic fit.
It's the same point Dr. Umar has highlighted. He did not find much improvement in the post-encephalitis sequelae patient. This is exactly what I have highlighted in my where it may not work. So in that slide, I'll just share that slide alone, where I have showed it doesn't work in post-encephalitis sequelae. I have already kept it there. Actually, Dr. Umar has just highlighted that point. In his case also, it did not work. But it works in hypoxic myoclonus, so that is where it works. So thank you very much for that.
Thank you, Ajay, because I was a little worried why it is not working at all. Actually, he came with this. There's 4 fits because he had maybe 1 fit every 3 months, but he had 3 fit in a month. So I had to stop that medication.
So it doesn't work. Actually, I have had a lot more cases of failures in post-encephalitis, and that's how I could make this. In fact, where all I have failed, I put a note. So initially I used to make a note. That's how I could make the summary of where it may not work. So that is how I got this.
Thank you.
Yeah. So good evening, sir. I'm Dr. Rajshekhar from Tirupati. So once again, sir, it's a very good presentation, Dr. Ajit, sir. I had a very few queries, sir. It's not my experience I'm sharing. Just asking, sir. So how much the maximum dose have you tried in pediatric doses and adult doses, sir? Just share with us, sir.
Sure. So basically based on the body weight of the individual. So if it is less than 10 kg, I don't go beyond 3 milligram.
Yes, sir.
So if it's around 20-25, around 4 milligram is the maximum I'll go. So once you reach 35-40, I go up to 5 to 6 milligram. I have had only one patient whom I have gone to 8 milligram. So usually in children, you see the effect around 3-4 milligrams sort of. So initial titration, you may not really see the effect because of the long T-half and other things. You start slowly seeing the effect by around 3 or 4 milligrams per day. So, and once you reach that dose, you can push to 5. Don't go to really to 6. So for 5, I go 4-6 alternate day. That is fine enough. There's no real need to break the tablet. So because of the long T-half, it doesn't make any sense.
Yes.
So you can go 4-6 alternate days. See what it does. Does it increase the drowsiness, or is there an advantage of improving the seizure burden? So if there is an advantage, push to 6. So that is how I will go. So that is how my practice has been.
So have you come across with the drug doses increasing due to enzyme-inducing drugs concurrently administered?
Correct. So what the pharmacokinetic says that because cytochrome P450 is common for the Perampanel, so enzyme induces, namely carbamazepine, phenobarbital, phenytoin, or oscarbazepine. These three drugs you may have to go to a slightly higher doses. I usually don't routinely use oscarbazepine because it's a weak anti-epileptic. I don't usually routinely use phenytoin. So in the patients whom I have on phenobarbital or carbamazepine, I usually push it up slightly higher. So maybe 1 milligram more I will go to before I will look for the real effect of the drug.
Thank you, sir. Thank you.
Dr. Banta, CYP3A is also a product where you find carbamazepine as well as ezogabine and clobazam, you must see, especially people who are using fresium, that they have got an effect on the drug. One should be careful along with all the, I always call it COP-CE, that he has already mentioned it. Carbamazepine, carbamazepine and phenytoin. And as well as CE is, of course, is clobazam and E is eslicarbazine and then ezogabine. All of them are interfering with the drugs. I think we have reached any other comment, 9, 10, because we are eagerly looking forward to Jnaneshwaran's final 15 minutes.
Sir, you have a code for everything. I think I had noticed you since long, and every time when I communicate with you, you have a code. Every code. Thank you. Yes, great. And to Ajit, what is the best treatment for hypothalamic hamartoma?
It's a very tricky question. Because all the hypothalamic hamartomas I have handled are really, really bad cases, and majority have ended up in surgery. Either we have gone for a radiofrequency ablation or for a resection of the stem. So I usually go with the lamotrigine, which is the best sodium channel blocker with a combination of sodium valproate. I will use. I don't usually go for a GABAergic inhibition because that can actually may aggravate the hypothalamic hamartoma, and Perampanel doesn't do good. If there is a Lennox-Gastaut LGS phenotype or the EEG is very, very bad, I use ethosuximide because that has a spike load reducing property in these patients. So if these three have failed, I usually take the patient for procedure, surgical resection. It's a very, very tricky game. And most of my hypothalamic hamartomas are very bad.
Ajit, any data on pregnancy and Perampanel?
Yeah, the current availability doesn't allow you to use, the data doesn't allow you to use in pregnancy because there is some risk of teratogenicity. So it's a big word of caution for pregnant females.
Hello, good evening, sir. ICU patient is there, sir.
Intellectual deficiency portion patient, because the Perampanel,
I think voice is broke.
Sir, you have to speak a bit louder. Sir, your voice is not.
No. The weight gain in Perampanel is because of the intellectually deficient people only. Mild and moderate. In severe cases, still more. But normal people do not get weight gain. This point must be mentioned to them. And second, I don't want people to stop Perampanel suddenly. This is the practice point. That can produce seizures. We have seen it. Because some people say they read that epilepsy and suddenly they stop the drug and they get the seizures. So one should not stop it. Those are the two practice pearls I wanted to mention it. Right. So now, I think when there are no other comments, I request Jnaneshwaran to give his final remarks on this whole episodes. You are the boss, please.
Yeah. Thank you, sir. Thank you, Professor K. And at the outset, I thank Dr. Ajit Ajit for his wonderful short and sweet sharing of the aspects of Perampanel. And the panelists also, everybody took very seriously came into a discussion. I thank Dr. Shivakumar from Bangalore, who stressed the point about the refractory myoclonus, especially post-hypoxic ischemic encephalopathy. And he was pointing about the falls due to Perampanel. And also to start low and to go
Sir,
slow.
keep mic
Am I
closer
audible?
to. Yes, now you're audible.
Yeah. So to start low, go slow. It has been emphasized by everybody. And I thank Dr. Sanjeev from Bangalore for his experience regarding cortical myoclonus and also cortical infarct producing cortical myoclonus and in some of the frontal lobe seizures also. And I appreciate Dr. Divya's comments regarding Perampanel usage in orthostatic tremor. That is a news and also in essential tremor as well as RLS. I think movement disorder people will seriously take up this drug on their side and start coming out with a lot of papers in the future. Also increase in the number of falls in PD if you use Perampanel in PD. And thank Dr. Kalpana for her experience in Travers. It's a very good point, and she has got good experience for in under 4 age group, because as such, though the literature says from above the age of 4 only we are supposed to use, and she has used in very young children, and that gives us courage to use in younger children also. And regarding the behavior problems that occur in especially in elderly, most of the drugs, many of the drugs, not only Perampanel, many of the drugs create behavioral problems in elderly people given inadvertently for something else. So we have to mind, especially in elderly individuals, usage of Perampanel, one should be careful about the age of 60. And in place of vigabatrin, in tuberous sclerosis, the usage of Perampanel has been stressed by Paiju as well as Ajit. And Sir, Professor AVS has pointed about the abuse potential, suicidal ideas, depression. One has to be very careful about all these things. One has to seriously go into the depth of the psychiatric comorbidity of the patient. And thank you for Dr. Sai for sharing your interesting point of giving a loading dose of around how much? I think you have given 12 milligram or 16 milligram through Rail Tube in status. I think that is I think you are the only one who has given in status epilepticus. And after that, what was the follow-up? You can share later. And I thank Dr. Umar, who has presented a very nice case of post-hanging hypoxia ischemic encephalopathy. Actually, we from Madurai have presented a series of papers on post-hanging hypoxic ischemic encephalopathy with various type of myoclonic seizures, plus or minus focal seizures. And it was an interesting case. And yeah, I think he has added around 7 drugs. At last, he has boiled down to 3 drugs, and the patient has come out well. And the main point to be stressed is a long T-off. Again, thank you, Ajit, for reminding again the long T-off. That is very important. For titration, you need not break the tablet. That is a very important point. One, I think the company people can take it as a clue when they promote the drug to the neurologist. Instead of breaking the tablet, you can alternate the dose. And thank you, Dr. Rajshekhar from Tirupati, for your interaction. And regarding the weight gain, actually, I don't know. Do all the patients on Perampanel gain weight? I think it is not mentioned about the weight gain due to Perampanel. And thank you for the nice point, not to stop suddenly. It happens to every drug, every anti-seizure drug, not to stop, because you will land up with breakthrough seizures. And I think I'll sum up, and thank you for the nice quotes and nice nice experienced talk by Ajit, and experienced comments by Professor ABS. And I thank the whole INTAS team for making tonight a wonderful day. And thank you all. Thank you all, sir. Over to you.
Thank you, sir.
Thank you, sir. Before we end, I would like to call on our SBU head, Mr. N.K. Jain, who has been the chief architect of ensuring that Perampa is available to your patients just the day after the patent got expiry. So over to you, Mr. N.K. Jain, to share your vote of thanks.
Thank you, Dr. Michael D'Souza. I will take this opportunity to propose vote of thanks for this wonderful scientific session, New Vistas in Epilepsy Management, Perampanel, new drug. And my sincere thanks to Dr. Evin Nivasan sir, Dr. Ganeshwaran sir, for chairing this session wonderfully and explaining everything and then summarizing whole summary of this scientific session. My big thank you, bigger thank you to Dr. Ajit Cherian, who has collected beautifully 132 experience, not less than any international speaker, and presented very well. Sir, you have really given us that where we should select patient for optimal outcome, a perspective on Perampanel. I appreciate your effort of collecting all the data and presenting us, which I'm sure Indian Fraternity of Neurologists will benefit from this, because they will get clear idea where they can use, where they cannot use this drug. My sincere thanks to all panel experts, because they have given their point of view. Dr. Umar for giving us one case study. So every one of you have contributed. Dr. Ganeshwaran sir has already mentioned, so hence I will save on time. I'm hopeful, sir, in times to come, this drug will prove I think great addition to your current treatment regimen. And I'm sure since this drug is available at a fraction of international price, your more patient will be benefited. At INTAS, sir, this Perampanel, we have got our own manufacturing. We have got backward integration of API. Hence, we are able to introduce this product from day one. And if US is getting benefited from our Perampanel, so I feel that we have all the right that our patient should also extended this type of benefit at Indian price. Hence, I would request each one of you have fair trial, place 20, 25, 30 patient, so that you can make your own judgment that where this drug will work and where you can use as add-on. And madam has given few new indication for Parkinson's also. Definitely we should try. So with this note, sir, once again, thank you very much for sparing your time, and good night for now. Stay healthy and stay safe during this pandemic time. Soon, sir, when market opens up, me and Mr. Michael will be traveling to South to meet all of you. Thank you so much. Thank you, sir.
Thank you so much. Thank you, sir. Thank you.
Thank you. Thank you, everyone.
Thank you, everyone.
Thank you, Srinivasan sir.
Thank you.
Thank you. Thank you, sir.